So while the production folks connect Sarah's camera, let me remind you that we have almost 500 participants in the room. And as Jenny, my colleague, was saying, we have people from Valencia, Venezuela. There is Jenny, and Colombia, Ecuador, from India, from Chile, El Salvador, and we also have more people from Venezuela, Panama, Colombia, South Africa, and we are having trouble here with the camera. Well, I don't see
So,
Tara, sorry.
Pedro, I'm right here. Are you seeing me? Thank you, Pedro. It's a pleasure to join you all from beautiful St. Lucia. As Pedro mentioned, I'm in the room with the participants from over 17 countries in the Caribbean who are committed to implementing the HEARTS initiative. So can I hear it for the countries implementing HEART? Let me hear a hooray. Today, as we join the rest of the region of the Americas in recognition of World Hypertension Day, we are happy that we're able to be here with you this morning as we recognize hypertension in the Americas as one of the leading causes of death in cardiovascular diseases. So we are all committed to play our part in managing and improving healthcare using our primary care, strengthening how care are provided at the primary care level for persons with chronic non-communicable diseases. So Pedro, back to you.
Excelente, Tara. ¿Qué energía?
Excellent, Tara. I can feel the energy. I've been a witness of the energy of all the people gathered there in that room. I've worked with the Caribbean team, but now let me go to the first segment. The first segment is walking with the heart champions throughout the Americas, and we have three panelists. I want to introduce them now, and I would ask them to turn on their cameras so that you can all see them. The panelists are Dr. Marcela Rivera. Marcela is a physician and is an advisor of the health department of the primary health care units of the Ministry of Health of Chile. Welcome, Marcela. Also, we have Dr. Matias Villatoro, who is coordinator of NCD's chronic diseases in the unit of health policies in the Ministry of Health of El Salvador. Welcome, Matias. And now we have also Dr. Shana Sir Filbert. Shana is Senior Medical Director and CD focal point for the Ministry of Health in St. Lucia. Shana and the rest of the panelists, welcome. It's a great pleasure to have you here. These three countries have been selected today to participate in this panel for this reason, because we're calling them the champions of hearts in the Americas. And I want to say that countries that are neighbors of Chile, El Salvador, St. Lucia can be motivated to learn what they have to do in their countries. One of the reasons why they're champions is the number of facilities or healthcare centers at primary healthcare level that are implementing the HEARTS initiative. And the purpose, and of course, purpose of our region is to reach 2025 with at least 80% of primary healthcare facilities implementing HEARTS. So we have some questions, Marcela. First of all, let me start with Chile. Chile was one of the first countries to adopt HEARTS, and they have ambitious goals. How are you with the escalation of HEARTS in Chile? What are you doing to reach 100% of healthcare centers in Chile? Hello, thank you. Thank you for your invitation. Good morning. It's a pleasure to be here. We were among the the first few countries to start with the Hearts Initiative, and we started slowly. We're trying to scale up, but we started training the network. 100% of health centers have to implement hearts by the end of this year. So it's mandatory. It's no longer optional. It's not a suggestion as it was at the beginning. It was a mandate for all health centers in the network so that they implement the the uh, the stepped method of treatment. We had the other pillars of the Heart Initiative. Some were more developed than others, but the one where we were lagging behind was the use of a protocol-based treatment, a stepwise treatment. There is solid evidence that if we can have a protocol-based system, it control of hypertension improves
Muy bien,
considerably.
Marcela. Hay un
Thank you,
mensaje que tú le has
Marcela.
dado
There is a
de
message
manera
that you have
clara a
given
esta audiencia.
clearly
El
to
Ministerio de
the
Salud
audience
de
here.
Chile
The Health
ha
Ministry of
entregado a la
Chile
autoridad política la implementación
gave
de HAR y ahí lo
number
pueden
one
ver
priority to the
de
Hearts
implementarlo, de
Initiative, and
institucionalizarlo en la
it
red
became
de
institutionalized. It's
servicios
now
públicos
mandated
de Chile.
in the primary
El
health care
que es un país,
network
y
of
estoy
Chile.
contigo, Marcela,
El Salvador, and I'll be back to you, Marcela, but El Salvador now is a country
ha dicho,
that
bueno,
was not
este es el
among the
camino, así
first to
tenemos
start, but
aquí a la
they
Junta Europea que nos va a
finally
implementar
decided that yes, this would
El
be
Salvador.
the way for them to
El
go.
doctor
And
Matías
now we have Matias Villatoro. How is how is the implementation of hearts working out in El Salvador for primary health care? Thank you, Pedro. Greetings to all, and thank you for the opportunity. Well, here in El Salvador, as you said, on February 24, 2022, we joined the Hearts Initiative, and so it's a little over a year. And we decided that this needed to be a political priority, and this political priority has been developed with the part of the integral approach to dealing with NCDs. And in our strategic plan for 2021-2025, we have that uh, strategic line. We have 9 priorities in our strategic plan, and one of them is reducing mortality due to cardiovascular disease. And the decision has been made to implement the Hearts Initiative nationwide as a cost effective strategy to uh, do a comprehensive approach in managing high blood pressure. An important thing is that as an integrated healthcare system, we include not only the ministry, but Social Security and other healthcare providers. So it's completely integral and comprehensive. And we have a technical team that leads the Hearts Initiative. We have 145 health centers, and we hope to reach 502 healthcare
Greetings.
centers,
My
which
name
would
is
be
Jeff.
87% of the healthcare centers in our country. And we hope that by 2024, we will be covering 100% of the health centers in our country. Another point I wanted to emphasize is the political will and the support we've had, the commitment and empowering of human resources, which has been basic. We have had to train about almost 3,000 human resources to implement this new model of care nationwide, and to be able to have a comprehensive person-centered approach.
Muy bien, Matías. Yo creo
Thank
que
you very much,
vamos a ir
Matthias.
resumiendo
Uh,
algunas cosas, lo que
Now, let us
Marcela y lo que
summarize
voluntad política,
among
¿sí?
the things that Matias and Marcela said. Yes, political will. We need that to make progress. And then assigning priorities. If we don't have priority in these programs, we cannot do it. And also to institutionalize the program, to have a strategic plan to be able to make progress. Chile
Al final de año
will
y
be reaching 100% of healthcare centers at the end of this year, and El Salvador will reach 87% at the end of this year. So this is a way in which we can be focused on one priority, and the pooled work by everyone
países líderes en el Caribe
will lead to this. So one of the leaders in the region is St. Lucia. They have 32 centers and they are
pero le
already
la palabra a
implementing hearts in 26 centers. But now over to Tara, and then she will ask our panelist, Dr. Shana Sir Filbert. Over to you, Tara.
Thank you, Pedro. So Shano, St. Lucia has been doing an excellent job in implementing the Hearts Initiative. You have commitment from the highest level, but how is scaling up going and what is the plan for full implementation within all primary healthcare facilities by 2025?
Thank you, Dr. Malcolm. Good morning. So far, we started with 6 centers in 2019, of course, before the COVID-19 pandemic. By 2022, we scaled up to 8 centers. We have so far scaled up to 20 centers. We have 32 centers in the country, and of course, we see the value of hearts, and we've incorporated hearts into everything we do at our ministry, whether it is a new program that we're starting or a project. And we are hoping to scale up hearts in all of our primary care centers by the end of 2023. How have we gone about the whole scaling up process? One of the key things we've done is to assess the gaps from very early on so that we can actually correct them as we go. And in 2021, we actually did a formal analysis of our implementation, and we did get lots of ideas as to what we were doing wrong and what we could do better. Based on this, we have used our governance structure, our technical committee. We've addressed some of those gaps, and we have increased sensitization, capacity building. We've retrained staff, especially coming out of the COVID pandemic. And like I said, we've integrated hearts into our regular program. So we have for performance-based financing, and for the other projects we're running, hearts is an integral part of that.
Thank you, Shana. So the plans are in place for full scaling up to 100% primary health care. And we recognize that the Hearts Initiative is a health system strengthening tool. And the reason countries are implementing this initiative is really to see those tangible benefits to patients. So what is your data telling you about this implementation here in St. Lucia?
So we have been collecting data, and of course through Hearts, we really saw the value of monitoring what we have been doing. So we have, through our health management information system, been able to pull the data in terms of control and coverage of our patients, and we do that across the various centers, in our primary care centers. And what we found is that our coverage of hypertensive patients has increased, so we've been tracking that. And not only has our coverage increased, but our control rates are increasing. So we've actually been able to look at specific clinics, and it's really great to see where when we started in 2019, 2020, they were, let's say, at about 19% control. To date, in April, we have those same clinics at almost 40% control because we've put the measures in place to improve the control rate. So it is a great thing to see because it's of so much value to our patients. Of course, Hearts offers a structured approach, and because it offers such a structured approach, especially in terms of M&E, it exposes the weaknesses of our health system. So as the weaknesses are exposed, we're able to address those and, of course, be able to go into our whole quality improvement. So, yeah, it has been great.
Thank you, Shana. So it's clear that the Hearts Initiative can help you to evaluate your performance. You can see what is working, where, and when, and it's also a quality improvement tool. So you heard it from St. Lucia. So back to you, Pedro. Let's hear what's happening in terms of Chile and El Salvador.
Tara, muy bien, excelente. Qué bueno tener ahí.
That was great, Tara. I'll give you a chance later on so that another country in the room and you pick the person. Today we saw an example of Trinidad and Tobago. And we saw what's happening in Suriname, what is being done in Guyana. And I'm very optimistic in view of what's happening in other countries. And I think we have to share that with the audience. Right now, we have more than 500 people with us here in the Zoom. And I'm asking my colleagues to report how many people are on YouTube so that you in the Caribbean can talk to these people on the different channels so that you can see what is happening. Now, Marcela, I go back to you. These are the numbers. If I ask you, Marcela, what are the concrete benefits of implementing HARTS at the primary healthcare level? So, Marcela, please go ahead. Okay, I would say that the benefits have been reported, and Kaiser has shared the evidence with us. I think that in all countries, COVID had a very sizable impact in terms of our control. We lost 10 percentage points in terms of our control rate, and that was a tremendous blow. And thanks to the HEARTS initiative, we were able to get these people back under control. These were people that were once again able to get their blood pressure within range. This makes it easier. Now, in 2020, 2021, there was also an impact on coverage. We lost 500,000 people in terms of their follow-up. And thanks to the fact that HEARTS is the predominant model, and since resources have been put into the network, we have gotten the population back under control. Now, effective control has not been achieved entirely. So our numbers show that with a standardized protocol in the centers where the protocol was being implemented, the results are much better than where there is no standardized treatment protocol. We here in Chile had the possibility, working with Dr. Ruiz Michea, to do a study, and that study was published in a journal that is devoted to the HEARTS initiative, showing the difference in populations that are completely comparable in the same districts with the same socioeconomic levels, the same settings. People that were treated with a standardized protocol had 70% control rate. Those not treated in a standardized way were at 30%. So the evidence is so robust, so conclusive that we showed those numbers to the rest of the country. We showed the numbers to the other health centers, and that is why we institutionalized and we gave the mandate that all centers had to apply a standardized treatment protocol. Wonderful, Marcela. Those are great numbers. So China tells us that in St. Lucia, they went from 19% to 40%. In other words, they double the rate. The control rate was twice as much. In Chile, where the protocol is being applied, the control rate went from 30 to 70%. Also, that means the rate was doubled. But I wanted to remind you of a number before I call on Matias. A number. Remember this. For each 1% that we improve the control of hypertension in the population, listen, for each 1% improvement in hypertension control in the population in the region, we can lower mortality from cardiovascular causes by 3%. Cardiovascular disease is the leading cause of death in the region. So for each 1%. So, Matias, what can you tell us about numbers from El Salvador? What can you tell us about hearts? Yes, thank you. We have had several concrete benefits, but in terms of controlling high blood pressure, we went from the baseline from 2019 to 39.9% of patients under control to 77.3% of patients under control at the end of 2022. And right now in the health facilities, we are at 84%. And for high cardiovascular risk patients, we are at 63.6%. However, there is another point that I would like to raise in terms of the concrete benefits of implementing the Hearts Initiative, and that is the reorganization of health services to care for chronic patients. First of all, the screening of the population, looking for risk factors. No longer are we looking for signs and symptoms, and that's important. And then another thing is the gateway for care is no longer in specialized centers, and we have facilitated the incorporation of new technologies. We didn't have the automated blood pressure cuffs that were validated in the primary healthcare centers. We're buying them, and they are following the technical recommendations of PAHO and WHO. And the other thing is incorporating single dose, daily dose. That was another challenge before we were doing Amplopril, and now we are incorporating this new technology. And also we have a standardized treatment following very clear steps so that the health staff at the primary healthcare level can implement, and the whole process has been facilitated. Let me come back to that. So the clinical pathway of hearts, the hearts model, is helping reorganize the way that we organize and deliver services. And the colleagues from the Caribbean agree. Now, Tara, this morning we saw an example. Well, today and other days too, we saw the example of Suriname and how things are changed in terms of the way that services are organized. So, Tara, could you have someone tell us about that? We have learned so much about this in the last few days. So, Tara, please go ahead.
Thank you, Pedro. So as Pedro mentioned, we have Suriname, we have Guyana, we have Trinidad, we have several countries from the Caribbean, and each have been implementing the initiative using various strategies. So for Suriname, would you like to share some of the key things that you have done in using the Hearts Initiative to reorganize and strengthen how care is delivered at your primary care facilities?
Yes, thank you, Dr. Ritesh Dhanpat, Deputy Director of Health of Suriname, also the Coordinator of Hearts Initiative in Suriname. So in Suriname, we started approximately 1 year ago with the preparation of installing an NCT, National Coordinating Team, and we involved a lot of stakeholders in that group, also the private sector. Because Suriname has a system that has both private and public doctors. So we implemented that. We saw the need of the evidence group for the standards for the treatment protocols. So we had also involved in that group all the stakeholders who were in the country at that moment involved and had the experience of developing protocols. And we started, and as we got along, we saw that there were some resistance coming from various groups. So we called the PAHO for their support, for guiding us through this process. And then at the end, we had decided that, yes, Suriname will also have that unified single how do you say it, simple protocol with 2 dose fixed dose combinations, and we started with acceptable treatment protocol and with the emphasis on where we are going to go with the preferred. I think in December we had our first training of healthcare providers, especially doctors, and in January we had doctors and their personnel, clinic personnel trained. In December at the first training, we had commitments at the highest level. The president did the launch for us, so we had the commitments at that level. And as I mentioned earlier, we had also committed that this is something that needs to be on that level of commitment. Otherwise, you will get a lot of obstacles. In that process of developing the protocols through implementation, we also had our systems for monitoring group in place. They looked at the DHIS2 tool, but because of some, we did not yet see the individual tracking of patients, so we developed our own monitoring tool in collaboration with the university at Suriname. So we had that also in place, and we started like in January. And in that regard, we have seen real life data of how the progress is going. Thank you.
So we have heard governance and having the highest level of commitment as part of that governance, and that is one of the contributing factor for success. We heard the data from Chile and El Salvador as it relates to the differences in terms of coverage and control. So I'm just going to give the mic to our representative from Trinidad and Tobago to just say what their data is currently showing.
Good morning, everyone. I'm Dr. Maria Clapperton. I'm the Director of Non-Communicable Diseases, Non-Communicable Disease Unit, Trinidad and Tobago. So I would like to thank you for the opportunity to share this morning. Hearts in Trinidad and Tobago, our experience has been a very good one so far. Heart has been very valuable to us in the sense that it provided us with an opportunity to introduce and implement a standardized evidence-based treatment protocol for the management of hypertension in primary healthcare. And that in its own way helps to strengthen our delivery of care in primary healthcare. Hearts in Trinidad and Tobago was launched in July 2019, and we started by piloting the program in 5 of our local health centers. Our baseline blood pressure control rate at that time was 20%. And by June 2022, we were able to meet our target scale-up of 100%, and we had 104 local health centers initiating the HEARTS program. And in 2022, in our follow-up, we observed that our blood pressure control rate had also doubled. So HEARTS has been very valuable, and we continue to review and improve the process, and we're grateful for the continued support from the team at PAHO.
Thank you. So you heard it. The data is strong, showing that this initiative works. So for countries who are still contemplating where they stand in terms of committing to the HEART initiative, this is your answer. It's time today, as we recognize World Hypertension Day, that you made that commitment. Over to you, Pedro.
Muy bien, Tara. Qué fantástico tener esta sesión.
Thank you, Tara. It's great to have this session. Just imagine 17 Caribbean countries, everyone speaking the same language and wanting to move ahead with the same aim in mind to deal with the most deadly disease. In the Caribbean, more people die every year because of cardiovascular disease, and more than 60% of that group have hypertension. Now, after the panel, and I'll come back to the countries later on, but now I wanted to call on Marcela, Matias, and Chana to ask you one question. If you had to give a short recommendation to the countries that are still on the fence, the countries that haven't been enthusiastic or invested enough energy, and I'm thinking about Central America, South America, the Caribbean, what would you say to the countries? Or what would you say with other regions, even in Chile? Well, first, this is not an experiment. It isn't something that's a pilot, because we often talk about pilots in primary healthcare. This is a care model that is useful. It can save many, many lives. And if we use it correctly, we are going to be changing the history of healthcare. It's just like washing your hands when you go into a hospital room. So not applying a standardized treatment, not using hearts is anti-ethical in my mind, because we are depriving people of the possibility of better health control, greater possibilities, better quality of life, and just gradually stepping up the treatment is not the answer in the countries of just getting started. So I would suggest that this be done in all health centers at the same time. And also we need monitoring. We need to give ongoing support. We have frequent meetings, and the whole idea is to change the paradigm. And the only way of getting that paradigm shift for care is by having meetings, by sharing experiences, by working together. So for me, and that's why I say it's an honor to represent Chile and all of the primary healthcare teams that are working on this. This is something that cannot be done alone. We all have to work together so as to accomplish our objective. So I would say that that would be my suggestion.
Thank you, Marcela. Matias, what would you tell your friends and neighbors in Central America? Well, it is a cost-effective strategy that we need to use in our countries. Our countries have had a great experience in the AS dot strategy, which is to reorganize health services. But this is a larger number of patients, but it is a cost-effective strategy, and it's an experience that ought to be used. And the other thing is we have some challenges that we need to consider, and they need to consider having an implementation strategic plan as the training of healthcare medical resources, have a record of the people to know whether the patients are being controlled or not, and if they're receiving the appropriate and correct treatment as prescribed. We need to have nominal records of people. We need to also use the treatment schedules that we already have in our medication list, and we can start with that. We don't need to be waiting until we have the fixed dose combined therapy medications to start. And that's an important point. We can start where we are with what we have, and also be aware that there are countries that already have some experience, and then we can support those other countries that are newer at this. Thank you, Matias. And now back to Tara for the last question with Shauna. Tara, over to you again.
Thanks, Pedro. So, Shano, what would be that one recommendation that you will make to the countries?
Thank you, Tara. I would say that hearts is something that our countries cannot afford to not do. As my colleague from El Salvador would have mentioned, it's a cost-effective strategy. And in our Caribbean countries, we know that money is an issue, and especially money being spent in secondary care. We don't have the relevant infrastructure, we don't have the hospitals, so we need to keep our people out of the hospitals. We need to keep them alive, and we need to keep them with a good quality of health. Hearts is evidence-based, and I believe, from my perspective, it's an evidence-based quality improvement framework that can be used for hypertension, it can be used for diabetes, for everything in terms of reducing our cardiovascular risk. Of course, there will be challenges. I think from the onset, I would recommend that countries monitor what the challenges are, what the gaps are, and the continuous monitoring will allow for improving what the issues are. I think also for our setting where we have issues with human resources, that HARTS offers through the team-based approach and the task shifting. HARTS offers that dimension where we could actually train our other staff and build capacity so that we can rise above the challenges that we have. Thank you.
Thank you, Shana. Again, HEART is a health system strengthening tool. So we have to use this initiative to continue to strengthen our health system at the primary care to deliver quality health care to the population. So I think that brings us to the end of our first panel. So back to you, Pedro.
Pedro.
Muchísimas gracias, Chana.
Thank you very much, Shana and Tara. One of the issues is that we always have time issues when we get together. We would need more time. Even though this room is full, this room has capacity for 500 people and it's full. And we also have the YouTube channels in English and Spanish. There are so many people who needs this information. You will see what we have next, and what we have next is the capacity of these kinds of webinars to train people who are on the field. And please take this survey. We have people who are connected, rural doctors from Ecuador, Colombia, Venezuela. They are in remote locations where they really don't usually have this kind of opportunity for getting this training. So how can we make this more widespread? How can we reach more people? Chile, Dominican Republic, Ecuador, El Salvador, Mexico, Brazil, Peru, Colombia, Bolivia, and we also have two countries that are not part of HEARTS as yet, Venezuela and Paraguay, but we have people attending from Venezuela and Paraguay. So they're taking initial steps. They're going to join HEARTS. And we also have people from Portugal, India, South Africa, Spain, Macedonia, Portugal. So Honduras is also here, Bolivia, Santa Cruz. So many countries are listening in. So when we go to the next segment, I would, before that, I would like to thank the panelists, your leaders of the HEARTS initiative in your countries. You are examples, inspiration, role models for those in the region. You're proving that by implementing HEARTS, you have doubled control levels, and you have extraordinary figures as those shown by El Salvador. And you are showing that you will get to 100% shortly. And so thank you all. And we're going to take a first break. Please, we have a pause to remind you that we have a special issue of the Pan American Journal of Public Health, where we have the experiences of all the countries that have documented their experience with HEARTS, and it's a very valuable resource for the countries who are planning to join. So over now to the pause, to our first break. Has over 25 original articles. HEARTS initiative in the Americas is seeking to improve hypertension control to prevent complications such as cardiovascular disease. Cardiovascular disease is the main cause of death in the Americas. How can you access the special issue of the Pan American Journal of Public Health? You can select it using your phone, as we're indicating here, or your any other electronic device. You can access the special issue on HEARTS in the Americas. and all the articles are free, and this is the link. Thank you very much for reminding us that we have the special issue of the Pan American Journal of Public Health, and it includes, and it's totally devoted to hearts, to the Hearts Initiative. This second segment will be devoted to the new resources being created by Hearts for primary health care teams. And Hearts has been constantly creating or co-creating in the countries where it is implemented. And there is a set of resources that are very practical for primary healthcare teams. Our first panelist will be Andres Rosende. He is a physician. He is has a master's in public health, and he is going to talk about the heart clinical pathway, regional approach, a regional approach. Over to you, Andres. Greetings to all in this World Hypertension Day. We are going to talk about the clinical pathway for comprehensive CVD risk. To give you context, let us ask ourselves what the health system is doing with our hypertensive population, a condition which affects 4 in 10 adults. And these people are going to go seeking for a solution in the healthcare system. But this system, in the end, does not diagnose some, diagnoses but not treats some, treats but not controls a third person, and only 1 in 4 hypertensive patients can reach their goal goal blood pressure numbers. So we are being warned here. The healthcare system is not solving hypertension. This is not due to lack of scientific evidence. We are far from those times where the doctor was closer to a witch doctor than to a scientific doctor. Today, we do have a large number of scientific articles from clinical trials, randomized clinical trials, and we know what interventions work and which ones don't. We have so much evidence that we need to order it. Otherwise, we're going to be swamped by everything, and we're going to sink in the large amount of knowledge that exists. And all this evidence has been translated into concrete recommendations over the years. They have become part of the problem because there is a plethora of clinical approaches, more than for any other conditions. There is no other condition in the whole world that has as many recommendations and methods to treat it as hypertension. So for 20 years, there was a concept of a standardized treatment protocol was devised to provide guidelines for treatment. Finally, in 2021, WHO launched its hypertension guideline for the pharmacological treatment of hypertension in adults. So there's a discussion whether a combination therapy is good for all hypertensive patients or not, and it recommends from the outset for treating all patients, preferably using combinations of antihypertensives in one single pill to reduce lack of compliance, and also takes into account cardiovascular risk, not to choose who is going to be treated and who is not, but rather to establish different thresholds for starting therapy and different additional therapies. And it finally includes the concept of the standardized protocol of treatment, and it also draws attention regarding the need to strengthen the team-based work so that nurses can manage the standardized protocol under medical supervision. At the same time, the innovation of hearts in the Americas published an extensive review of the most successful experiences regarding hypertension, defining eight key actions that need to be carried out to improve uh, the quality of the healthcare system. And now we come to the point where we have very robust guidelines based on evidence with standardized treatment protocols, which are simple and which are a concrete tool for implementing the strategy and a whole frame of reference for the continuous processes to improve quality. So how do we integrate all these tools in an efficacious manner? And this is where the hypertension heart pathway does. So we have the hypertension clinical pathway. It has diagnosis and treatment protocol approaches with validated blood pressure measuring devices. At the center, we have the protocol of standardized treatment, which is not exclusively for hypertension, but it also includes treatment with aspirin and statins according to the estimated cardiovascular risk and whether there's history of established cardiovascular disease. And finally, regarding hypertensive treatment in particular, it integrates pharmacological measures with non-pharmacological measures, and there are 4 steps for therapeutic steps to achieve goal, which is treating with 3 drugs at full dose and recommending as well the use of therapy with 1 single pill to diminish therapeutic inertia and improve compliance. We also have other recommendations for managing patients at the primary health care level, such as follow-up intervals according to risk, providing medications for a prolonged period of time, as well as integrating it with communicable diseases and other measures, for example, vaccines. And we know this because we've learned it through through the COVID pandemic. So CARTS is becoming an institutionalized method to do comprehensive management of hypertension in the Americas. And why do we need a clinical pathway if we if we have reached this point, and I have not convinced you, the clinical pathway gives solutions to those who manage public health, and they become, or it becomes a management tool which is comprehensive, which provides solutions for the primary healthcare team that works at the health center. And ultimately, it empowers the patients and their families, informing them about what their rights are regarding control of hypertension and management of their cardiovascular risk. How have we progressed in the region toward this very powerful model? Recently, there was an article published describing the work we have done with several countries that make up the Hearts Initiative. We have built a standardized evaluation tool based on evidence to evaluate the efficacy of treatment protocols. We have taken countries that have been implementing hearts in the past years, and they had the standardized treatment protocols, and they've done both mirror assessments and self-assessments. And at the same time, countries that joined later, the Hearts Initiative have received the clinical pathway model to guide their process. At the end of a year, clinical pathways have been defined for most countries in both cohorts, and we've seen that there has been a significant improvement in the general score of quality and in each one of the three domains included in the questionnaire. And countries in the second cohort have reached scores which are equivalent with less variability as compared to countries that have been there years implementing the initiative. So what this means is that we are generating a way in which we do things, which is uh, disseminating and allowing us to reach our goals more quickly. And so this is how the clinical pathway is being used in the countries. The countries are adopting the clinical pathway to their own designs. The paper has also revealed which the which are the gaps that need to be bridged as yet. It has to have a high quality. It needs to be institutionalized, and it needs to be adopted nationwide. And the instrument needs to uh, be updated using also high level statins that need to be available at primary health care. And it's not only for specialists. And the work-in teams should be reinforced at all levels with the community workers who measure blood pressure. We have the pharmacists taking care of medication, monitorization, and nurses trained and supervised by doctors. The clinical pathway presents the evaluation of the protocol, which is a standardized protocol for treatment, which is instrumental for fully enforcing the WHO set of guidelines, and it includes chronic kidney disease, diabetes, and other cardiovascular diseases, and it promotes equity and promotes health for all, and it is being adopted by most countries of the region. However, some of these countries continue to use complex treatment protocols. The clinical pathway needs to become institutionalized and become the gold standard for national care to manage cardiovascular risk in primary health care, and having access to fixed combined drugs and high level statins of high quality, as well as aspirin. And the clinical pathway needs to become a reality that will strengthen our healthcare systems. Thank you very much for your attention.
Thank you, Andres. Thank you for this very valuable testimony showing how this is a valuable tool so that new countries that are just joining the initiative can have a model and know how to target their efforts in applying such a powerful tool as hearts. So first I'm going to go to Tada, because in our Caribbean workshop, we have a lot of new countries, and perhaps you could mention them because you're better acquainted with them. What would you say if you asked some of the new countries to give a report? They could tell us how we're doing with the clinical pathway. I was impressed by what Bermuda was saying. Bermuda is a country that just joined, and I would like to hear how they're doing, and other countries from the Caribbean too. So Tara, please go ahead.
Thank you, Pedro. So we do have several countries here that are at the pre-implementation stage of HEARTS initiative. We have Grenada, we have Bermuda, we have Montserrat, Anguilla, we have St. Vincent and the Grenadines, we have several countries. But I'll start with Grenada for them to share what aspect of the HEARTS initiative they think will have the greatest impact on the management of hypertension in their country.
Thank you, Tara, and good morning to everyone. Actually, Grenada is quite excited about implementing HEART, so we think that every aspect would have an impact. But what we're most looking forward to is implementing the standardized clinical pathways, because currently what we're doing is physicians are basically prescribing based on their personal preference or what they would have learned. And we've seen from the evidence and what the outcomes in other countries that have hearts with a standardized protocol in place, the great improvement they have in outcomes for their patients. So we think that that aspect for now would definitely have the most impact for us.
Thank you. So you've heard from Grenada. Let's hear from Bermuda.
Good morning, Tara, and morning to everyone online. So we in Bermuda are at the stage of pre-implementation / implementation. We have ratified our clinical guideline, and we are about to launch in 3 sites. In Bermuda, we are launching in two private sites and 1 public site. So we are data collection, and we are going to ensure that all the facilities that need to be at those sites are there. And when we go back, we hope to launch and have some pre-implementation data. So that's where we're at. And we're very grateful for the couple of days here. We've learned a lot from the experiences in the other countries. So we're taking that back home with us. Thank you.
Excellent. So one of the reasons for this workshop is really networking, for us to share our experiences, the challenges, of course, and some of the strategies that have been used to overcome those challenges. As a Caribbean, we're similar, but we also have differences, and there are opportunities for us to learn from each other. So I'm now going to ask our representative from Belize to share their experience.
Thank you. Good morning, Dr. Cuellar, Deputy Director for Public Health and Wellness, Belize. The clinical pathway is something that I agree with the colleague that spoke a while ago, that we have to standardize the way we're going to treat hypertension. But we're fortunate because in our drug formulary, we already have all the medications that are required to start. We do not have the combined pill therapy in a lot of cases, but we can start with individual medications and certainly get on their way with hearts. We signed on late last year, and we're looking forward to start implementing in the next few months. Thank you.
Thank you. And he made a very important point. We're going to start with what you have now. So based on the medication that you currently have on your formulary, you're going to use that to get started. But as you plan ahead, you will look towards adjusting your formulary to take on those fixed dose combination or single pills that you will be able to then improve on your protocol. So, Pedro, it's over to you again.
Excelente, excelente, Tara, excelente.
Excellent. Great, Tara. I was really happy to hear the reaction from the countries. And I want to say something we've been discussing in this workshop, and this is something that we keep pointing out, and that is how important it is to involve academia, to get the medical schools involved. The nursing schools have to teach differently. So we have to change the way we do things. And in the chat, I have gotten a message. Dr. Maria Elvira Lopez Olvida and Ana Sanchez Peña teach at the Universidad Complutense de Madrid. This has nothing to do with the Caribbean, of course, but they are in the Complutense University in Madrid. And in that university, they are using the tools that we created in Hearts. They use them as a teaching tool for their students. So this is something that different countries are doing. Dominican Republic has institutionalized using Hearts educational materials. Chile is doing the same thing, other countries too. So something I wanted to point out before we get into the next resource, the next resource has to do with the application of Hearts. Many of you are acquainted with that, but the new thing today, Andres, is that what Andres said wasn't left up in the air somewhere. It has to do with the application, the implementation of Hearts. And today, as part of our celebration of World Hypertension Day, we are sharing this great news, and that is that the implementation of Hearts has been updated, and it now has the protocols approved by the countries that already have protocols that already have the clinical pathway. So here I have Engineer Livardo Rodriguez. He is an engineer, and he's going to be talking about the implementation of Hearts. So please go ahead, Libardo. Thank you. My name is Libardo Rodriguez, and I am part of the data team for Hearts in the Americas. Along with the team, we have done some updates to our cardiovascular risk calculator, which is something that can be accessed from the webpage having to do with Hearts in the Americas. So here we have the cardiovascular risk calculator, or you can go to our preference search and we can look for cardiovascular risk calculator app, PAHO, WHO, and that takes us to a web page where we can see all of the information having to do with the use of the app, including an introductory video on how to use it. Also, there are hyperlinks that can be downloaded for different applications, and they will be available late this month. We can already get the web version by clicking on the button so that you can get there from your search engine. Here you can choose the language you prefer. We have English, Spanish, and Portuguese available, and then you can select your country. In terms of the new changes we made to the app, for those of you that are already using it, we have restructured the main menu. The whole idea is to focus more on institutionalizing the clinical pathway. So we have a quick guide with a step-by-step on how you should correctly take blood pressure by using validated blood pressure devices. As far as estimating cardiovascular risk, we have a list of questions. And if the answer is yes, it would take you to the clinical pathway for the country. For example, if you have a history of cardiovascular disease, if you clicked on yes, then I get an alert for high-risk patients, and that takes me to the clinical guidance proposed by the country. Here I can see all of the therapeutic recommendations, or I can click on Open PDF. And here I can download, I can share, or I can print out the document so as to share it more widely. This is a process that I can repeat for any sort of calculation. That's do you have diabetes? Do you have chronic renal failure? And here I get an indication of what type of patient this is, risk or high risk. And it takes me to the clinical pathway. Now, in case the answers are no, then we are taken to a question asking about cholesterol levels. If I clicked on yes, I may include cholesterol in blood levels. So here I make the calculation, and it shows me the 10-year risk profile. At the top, I have direct access to the clinical pathway, and towards the bottom, I have the recalculate in case I wanted to change those variables. And then I have a button to do a new estimate of the risk. If what I'm trying to do is go directly to the clinical pathway and therapeutic recommendations, I can do that from the main menu. Now, in the case of the countries that don't yet have an approved clinical pathway, the app does show you the standard clinical pathway that is suggested by the Hearts team.
Igualmente, la puedes descargar, compartir.
Also, you can download that, you can share it with others by clicking on where it says Open PDF. For other calculations, we look at glomerular filtration rate, and also you can get to body mass index. Here we can do the calculation, and here we can see the BMI.
El instructivo también se modificó un poco. Ahora
Also,
tenemos
we changed the instructions a bit. Here we have access to different publications. We have the risk table calculators, so you can click on this hyperlink.
el cual nos dirige al paper.
It takes us to the paper that contains all of the tables behind building this application and also the process on how the app was developed. If you click down here, you go to a paper called Clinical Tool for a hypertension and high cardiovascular risk. Here we have instructions on the use of this app, and under clinical pathway, we have that hyperlink that takes you to the clinical pathway as a means of managing hypertension. This takes us to that paper, and we can download or share that publication. Also, we have information on hearts in the Americas. Also, we have what this calculator does not include and warnings in terms of use. So thank you very much for your attention. Thank you, Libardo. So we now have this ability, and it's something we can share with countries too. How many users are we going to have in the countries? We have something like 250,000 people who use the risk calculator almost daily. So if people don't know that this calculator does exist, if they don't know that this tool exists, they're not going to use it. So I would recommend that the countries use this, that they share the link to the calculator. It is on the Hearts webpage. Also, there are different platforms for smartphones. So this is an indication of what needs to be done if we want to broaden the use of this tool so we can put in the hands of primary healthcare providers this tool. It has to be part of the protocol. It has to be in the hands of the people that need to use it in the countries. Now, the next presentation is another resource that we created in Hearts. This is something that when people begin to use a standardized protocol, even for usual treatment, they're concerned in terms of using medication. So for that purpose, the Hearts team has created a course. It's a virtual course that is on our platform of Public Health Virtual Campus to manage antihypertensives, to educate physicians, healthcare teams about using these medications. And there we have with us Dr. Jeffrey Brettler. He works with Kaiser Permanente in Southern California, in Los Angeles, and he was the director of the course that we're presenting today. This is a course that is already available in the virtual campus. So, Jeffrey, please go ahead.
Greetings. My name is Jeff Brettler. I'm an internist and hypertension specialist, and I help co-lead the hypertension program at Kaiser Southern California. I'm also a consultant for the Pan American Health Organization. And it's a pleasure to be with you today on World Hypertension Day to talk to you about a set of courses we've produced called Supporting Primary Healthcare Teams to Use Blood Pressure Medications Effectively that we think will be a very valuable asset to all primary healthcare teams. It's important to start by saying that our course content is completely aligned with the World Health Organization's new and outstanding set of recommendations on the guideline for the pharmacologic treatment of hypertension in adults published in 2021. And this guideline gave us a number of excellent recommendations on many aspects of hypertension care, but told us specifically which medications to use and stressed the importance of a fixed dose combination pill. So what is the guideline telling us? Well, with a strong recommendation with high certainty evidence, the guideline states we should be choosing from 3 classes of pharmacologic agents for the initial treatment of hypertension. thiazide and thiazide-like agents, ACE inhibitors and angiotensin receptor blockers, and long-acting dihydropyridine calcium channel blockers. They also give us some implementation guidance, notably that long-acting antihypertensives are preferred. And the guideline goes on to stress that combination therapy, preferably with a single pill combination, should be used as initial treatment. Very important point. And that's because multiple studies have shown that a fixed dose combination pill improves adherence and persistence of taking medication. We now know what to do to ideally treat hypertension. We need to use a preferred medication protocol with a fixed dose combination pill, and we need to intensify treatment per that same protocol when the blood pressure is uncontrolled. But there's a big gap that follows. How do we reinforce and keep patients on the right medications? And to do this, providers really need to understand how to manage common side effects with these medications and how to deal with common lab abnormalities. Now, hearts provide us with a very valuable tool, the hypertension clinical pathway, which essentially bring together all of the evidence-based strategies we need to do to improve blood pressure control. And in the center of that pathway is the preferred medication protocol. This protocol is consistent with the WHO hypertension guideline. It's also important to note that the pathway incorporates blood pressure drugs which are available through the PAHO Strategic Fund at competitive prices. And we know that keeping patients on medication for chronic disease is very challenging. This study, like many others, shows that after about 1 year, adherence to hypertensive meds is only about 50%. And as healthcare providers, we often think of adherence solely as a patient problem, but it really is much more complicated than that. And this study shows nicely multiple factors from multiple systems which really play a role. So how we talk to patients is important. How do we employ team-based care? How comfortable are providers with side effects, etc.? How complicated is the regimen? How long is the refill frequency? These are all important determinants in whether a patient is adherent to their medication. And perhaps one of the most important set of issues to address are those coming from our healthcare providers. So do our providers have adequate knowledge and comfort regarding medication initiation and dose escalation? Are they comfortable dealing with side effects? Do they know how to deal with comorbidities or treat the older patient? And frankly, are there potential misconceptions or myths that providers have regarding specific medications? And in particular, we want to focus on maximizing the comfort level and the use of our preferred protocol blood pressure medications. So that is going to focus on the following. Understanding which common side effects are dose-related. As an example, the peripheral edema that we see with calcium blockers, which in that case, we can minimize with dose adjustment or other strategies. Understanding which common side effects require medication discontinuation, like the cough associated with ACE inhibitors or angioedema with that same medication. Knowing how to deal with basic lab abnormalities, and increasing the comfort level with the use of spironolactone, which is highly effective in resistant hypertension. Our set of courses are based on actual clinical cases. So here's a very typical example that we see commonly in practice. A patient on maximal dose of 3 preferred medications, ACE inhibitor, thiazide, and calcium channel blocker, who develops bilateral pedal edema. And here are some typical options that we see in clinical practice. In these courses, we'll review the relevant studies which really support use of various strategies to deal with the common side effects. As an example in this case, addition of a RAS blocker in a patient who develops edema on a calcium blocker has been shown not only to significantly improve blood pressure control, but also to decrease the edema in a majority of the patients. And we'll advise some practical do's and don'ts, which are all evidence-based. To continue with this example, reassurance may be the most appropriate next step. The edema is physiologic and not pathologic. And to not prescribe a loop diuretic, which is often done in these cases to treat the edema. So here's a list of the full content of the courses. Beginning with thiazides, we address hyponatremia, hyperuricemia, other metabolic disturbances. and how to use thiazides in chronic kidney disease. With ACE and ARBs, we'll deal with the cough and angioedema we see, and importantly, how to manage potassium and renal function on these medications. We spend a lot of time talking about edema with calcium channel blockers. It's the main side effect that we see with this medication. We also deal with erectile dysfunction, which is a common barrier, or at least perceived barrier, by both patients and providers with the use of blood pressure medications. And then lastly, we'll review tips for how to use spironolactone safely. And finally, here's a listing of the actual course modules, of which there are 6, including an overview module. These are currently available in English in PAHO's virtual campus, but should be available in Spanish shortly. And we feel that any provider who's involved in the treatment of hypertension, including physicians, nurse practitioners, pharmacists, and nurses, would all benefit from taking these courses. We think that you'll find these very evidence-based and very practical, and should go a long way in improving the care of your hypertensive patients. I want to thank you for your attention today.
Would try to promote it among my healthcare teams to take the courses. People are concerned, they have fears, they have limitations whenever they are prescribing a drug, and this course can help and accompany doctors and other practitioners to implement the HEARTS pathway, clinical pathway. We're almost an hour and a half into our program. We will have a break now, and this will be an active break. And we are going to have something which is the HEARTS anthem. It is part of the enthusiasm and the energy they have in St. Lucia. Look at what St. Lucia has done to make our break an active break. Some of you are familiar with this, but now over to you, Tara and St. Lucia in the room. How are you going to lead us?
Bueno, en este caso fue una pausa activa express.
This was an express active break. We didn't have enough time, but it gives us an idea of what we can do. So, Tara, before going to our keynote speaker, who is Dr. Donald DiPetti, let's go back to the Caribbean room. I'm calling it the Caribbean room because, you know, seldom do we see a room full of people all from the Caribbean, from 17 countries. We have the course, we have the calculator. Tara, why don't you ask them how they're thinking of using the calculator for cardiovascular risk? And tell us. And over to you, Tara, now.
Thank you, Pedro. So I'll start with Guyana. Can you share which of the HEARTS tools you have been using in Guyana, and what's the plan for scaling up on those tools?
We're basically utilizing the, treatment algorithms, which we developed through an interprogrammatic agency and other agencies, for example, pharmacy, our central hospital, PAHO, along with some private entities. We're utilizing those clinical pathways. We developed one, an immediate protocol, along with a preferred. The reason we did the immediate protocol was we wanted to utilize the drugs we already had in our system, so that all the physicians can utilize these drugs at the necessary dose, or utilizing the protocol which we had already printed in collaboration with PAHO under the HEARTS initiative, while we procured the drugs that we ideally wanted, which would have been for the preferred protocol. Only about 3 months ago, we managed to procure the drugs for the preferred protocols, and this is on its way. So we're hoping that this would give us, those benefits we want and see the better outcomes of these patients, especially relating, since we would now have better quality drugs, and the fact that there's the standardized treatment protocols for all the physicians to follow should be a plus. And it's not just the physicians, but in the hinterland region, like the team-based care, we want to also decentralize some of the work from the physicians to the non-physicians. So with the presence of these protocols, which we need to strategically place in all the different facilities, health facilities, so that it's there, you can see them and follow them, so that some of these non-physicians, especially the community health workers in those hinterland regions, can follow and help to better the care of these patients. Because as we know, Guyana is one of the leading countries with premature deaths by cardiovascular disease. And we hope that through the HEARTS technical package, we can have better care and treatment for these patients, and at the same time have adherence from these patients in order to decrease the mortality rate of cardiovascular disease in our country.
Thank you so much, Michael. So we'll pass the mic to St. Lucia. Can you share whether the app or any of the virtual courses are being used in St. Lucia?
Thank you, Tara. Both the app and the virtual courses are being used in St. Lucia. The app has been integrated in our health information system, and we just need to promote it a little more so that it will be used at all our wellness centers. The course we have been using from inception, and we have a number of healthcare workers who have completed the course. Because St. Lucia has been implementing HEARTS from 2019 and we had the pandemic, now it's an opportune time for us to go back and promote HEARTS and to do our continuing education to ensure that it is continuously used in our health system. Thank you.
Thank you, Yolanda. And I'll take one more country. So I'm going to move to one of our newer countries, Antigua and Barbuda, to speak to what are the plans that they have in place to utilize some of these HEART resources in the country.
Hi, good morning. Thank you. So I'm Dr. Camaria De Castro. I'm an internist with the Ministry of Health. So what we plan to do is to expose our doctors to the app, which is available for free. You can download to your Android or iPhone, and you can use it actively once you're at work and you're seeing patients during a consultation. One of the things I noted, it's very user-friendly, and it gives very clear instructions that a GP can use or can initiate or follow once the patient is before them. And of course, it means more work for me because I do see that it says refer to specialist here. But you know, the patient can be treated by the GP with initiating like statins, for example, which we know are very underprescribed, and those give very big benefits for patients with cardiovascular risks already established. So that's one of the things I was really happy to see, and I think it's going to be very useful for us. We're going to see great outcomes once we have that adherence. And I know one of the big things is that we have to try to overcome inertia by physicians who are not, readily and actively treating patients' individual risk and customizing the treatment. I know it happens across the board in all countries, and I'm really happy to see that this is very user-friendly and very instructional as well. Thank you.
So
There you have it. The Hearts Initiative have various resources available to countries to really help in rolling out and implementing this initiative throughout the country. So back over to you, Pedro.
Muchísimas gracias, Tara.
Thank you very much, Tara. Here, we're happy to see that the resources are being used, and you know that new programs and some iconoclastic things that with paradigms, all these things are suspect on some of the parties. So we always have to say that Hearts is an evidence-based program, solidly evidence-based. As Marcela Rivera said at the beginning, it is not an experiment. We are sure that we are doing the right thing. And for this reason, Hearts needs to continue to use strong, robust, and healthy science. And this is why our keynote speaker, Professor DiPetti from the University of South Carolina at Columbia in the United States, he's going to talk about science for a healthy and strong heart. He is our keynote speaker, and this will be the last segment of this webinar. Please, over to you, Dr. DiPetti.
Well, it really is an honor to be asked to join the celebration of World Hypertension Day today. I've been asked to discuss some recent landmark publications or studies, if you will, regarding hypertension, but more importantly, that have practical implications for hearts in the Americas. I think this is a timely presentation because we've just come through, obviously, a horrendous pandemic. We've not been together one-on-one, et cetera. So it's probably a nice time to review some of the studies that probably were published and took place during the course of those years. First of all, let's look at some of the study categories that we're going to review today. Number one, we're going to look at population data. And there's going to be the NHANES report in the United States in this category. Let's turn then to guidelines. And we're just going to very briefly mention the WHO recent guideline on the pharmacologic treatment of adults with hypertension. Then we're going to turn our attention to cardiovascular risk prevention, pharmacologic treatment, which will discuss not only the time of day of pharmacologic administration, but also some new information on renin-angiotensin system inhibitors, as well as a single pill combination versus a multi-pill combination. Then we're finally going to end with team-based care and a brisk discussion on its benefits. And then lastly, talk about addressing disparities in hypertension control, which is obviously important to all of us. Well, as just suggested, we're going to discuss first the NHANES data, which is our population data here from the United States. There was something remarkable about our most recent report, and it was published in JAMA of 2020. And really, this resulted in a reevaluation of our population blood pressure control rates and a call to action, as you're going to see. In the United States, for decades, we've been incrementally improving hypertension control, even with the definition of control being less than 140/90 millimeters of mercury. We reached a peak to about 54% in the 2013-2014 survey. And all of us said, let's just keep doing what we're doing because we have incremental improvement. Well, lo and behold, that did not happen. In the report from 2017 to 2018, something remarkable was evident. Number one, our hypertension control rates, again, using the barometer of less than 140/90 millimeters of mercury, actually significantly decreased to approximately 44%. This is the first decrease that we've ever seen since accumulating this data. That is itself very ominous. However, if we use the newer criteria that some are using now from the ACC-AHA guidelines of hypertension being less than 130/80, that hypertension control rate now is only 19%. Well, it would be one thing if it was only a number. But actually, this reduction in hypertension control rates parallels the recent increase in cardiovascular disease, morbidity, and mortality, particularly stroke. Well, this data, which was published right smack in the middle of the COVID pandemic, really caused alarm. So much so that the United States Surgeon General issued a call to action for hypertension control right in the middle of the pandemic in 2020. What the Surgeon General issued was 3 goals. Number 1, we need to remake hypertension control a national priority. 2, we have to ensure that places where people live, work, learn, play, support hypertension control. It has to be all-encompassing. But more importantly, we need a new strategy. We need new strategies to optimize patient control for hypertension. And strategy A was to advance the use of standardized treatment approaches and guideline recommended care, including a hypertension formulary and treatment protocol. Clearly, this has implications for hearts. In fact, it reinforces the need for hearts, including in high-income countries now, not just in low to middle-income countries. Let's now move on to the guidelines. And one of the guidelines that was published again in 2021 on the WHO website, but the executive summary was published in Hypertension in 2022. And I was very fortunate to be a member of the guideline committee as well as the writing committee. The WHO guidelines covered 6 major issues and 8 recommendations. We're not going to go over each one of them. We do not have the time, but the guidelines included blood pressure threshold to start treatment, whether laboratory or cardiovascular risk assessment is needed prior to starting pharmacologic therapy, which drugs, and more importantly, in combination therapy. The target for blood pressure control was also included in the guidelines, as well as recommendations for rigorous follow-up and timely intervals when we re-see the patient to adjust medications, titration, and reevaluation. And lastly, there was a guideline on the use of non-physician healthcare workers in the further management of hypertension. You can review these guidelines, of course, by ourselves. On the other hand, they had significant implications for the Hearts program. And as can be seen, they're all included and aligned with our current hypertension clinical pathway from Hearts in the Americas, as you can see. The pathway includes cardiovascular risk assessment. It includes when to initiate blood pressure treatment. It also includes the targets for blood pressure treatment, as well as other modifying cardiovascular risk factors entities, such as aspirin and statins. It clearly includes a treatment protocol with examples for medications and dosage, including starting with combination therapy. And lastly, it addresses the timely follow-up necessary for both while you're attaining control, as well as once you obtain control. And it also talks about the need for vaccinations, et cetera, which is also in the WHO guideline. So the WHO guideline and the hypertension clinical pathway are clearly aligned. Let's now talk about individual studies. The first study we'd like to talk about is trends in the provision of medications and lifestyle counseling in ambulatory settings for patients with atherosclerotic cardiovascular disease. This was just recently published in JAMA Network. Well, what's the issue that prompted this paper? Number one, the use of statins, aspirin, and lifestyle counseling are clearly a benefit in the secondary prevention of atherosclerotic cardiovascular disease. However, the gap is that population data on the use of these strategies is lacking. The investigators in this study performed a cross-sectional study using the United States National Ambulatory Medical Care Survey in adults, as defined as greater than 21 years of age with atherosclerotic cardiovascular disease. The outcomes, of course, was statins aspirin therapy, and lifestyle counseling were monitored at each clinic visit. Well, let's see what the results demonstrated. This graph demonstrates the results over approximately 10 years of the study from 2006 to 2016. And really what's remarkably alerting and alarming is that the fact that many of these measures did not increase. Aspirin and lifestyle counseling increased slightly, but actually lifestyle counseling actually decreased over this period of time. So what can we conclude from this study? Number one, since 2006, there's only been modest increases in statin and aspirin prescription for those where it's clearly of benefit. However, lifestyle counseling has actually decreased. I didn't show the data for time. However, women and Black patients lagged even further behind. So what is the implication for hearts of this study? While they're all part of our hypertension clinical pathway, we still need to be rigorous. We need to be alerted. We need to place greater emphasis, and population strategies for all three of these interventions are needed and should be reinforced. Let's turn our attention to pharmacologic treatment. The first study is just the timing of pharmacologic treatment. When should we advise our patients to take their medications? Well, this study is the cardiovascular outcomes in adults with hypertension study, and it examined evening versus morning dosing of all antihypertensives taken at once. It's also known as the UK time study since it was done in the UK. The issue was there's been recent studies, predominantly from one center, that suggested that evening versus morning doses of all or some of the prescribed antihypertensive medications results in greater blood pressure reduction and cardiovascular outcomes. However, this data has been controversial. So clearly, a study is warranted. The time study was prospective. It involved two groups of individuals with hypertension, approximately 20,000 people. And it examined taking all the medications in the morning versus taking all the medications in the evening. The outcomes were primarily vascular death, hospitalization, or non-fatal myocardial infarction or stroke. Let's just look at the graph on the right-hand side of this slide, which compares over approximately 10 years of the follow-up of these patient populations between those that were prescribed an evening dose, shown in blue, and those that were prescribed at the morning dose in red. It is clearly evident to see, without even looking at the actual numbers or statistics, that there was no difference between the two. This is in the primary cumulative outcomes. If we look at the individual, not only the primary composite endpoint, but also the individual secondary points shown on this table, there was also no statistical significant difference between any of the measures between those that took the evening dosing versus those that took the morning dosing. So again, what's the take-home message from the UK time study? First of all, the authors themselves concluded that patients can take their regular hypertension medications at any convenient time that's appropriate for them. So the implications for hearts is this study brings clarity to the debate of dosing time and medications. And fortunately, in a good way, it increases the flexibility for patients. They can take it whatever's best for them. That's going to increase their medication adherence. Clearly, however, once daily dosing is still key, irregardless of the time of day. We're going to turn our attention now to renin-angiotensin system inhibitors with this study. Comparative first-line effectiveness and safety of angiotensin-converting enzyme inhibitors versus angiotensin receptor blockers in hypertension. So again, what was the issue that brought about this study? Well, number one, our ACE inhibitors have a much longer history of use than our ARBs since they came first. Both of these agents are recommended under the classification of renin-angiotensin inhibitors in almost all hypertension guidelines in the initial management of hypertension. So they're recommended presently at approximately equally. So this study actually was multinational and retrospective. It was patients with hypertension on monotherapy with either an angiotensin-converting enzyme inhibitor or an ARB over a course of years. The outcomes were cardiovascular endpoints, as well as safety of the two classes of medications. Interestingly, in the study, 2 million people were on the ACE inhibitor, while only 600,000 individuals were on the ARB, clearly demonstrating that right now, presently, we prescribe ACE inhibitors much more frequently than we do ARBs. Well, let's see the data. What did these investigators find? In the top table, they found, looking at their outcomes, whether it's myocardial infarction, cardiovascular endpoints, heart failure, or stroke, there was no difference in outcomes between those that received the ACE inhibitor versus the ARB. So thus, there was no advantage in outcomes over each. They both did the same job. And also, you can see the individual studies that were looked at as well in the primary effectiveness outcomes. But more importantly, on the bottom, although, again, I'm not going to show the data, ARBs had significantly lower risk of angioedema, which can be life-threatening, cough, pancreatitis, and GI bleeding. So despite the equal efficacy in terms of cardiovascular outcomes between ACEs and ARBs, if you will, the ARBs had clearly a much more beneficial safety profile. So again, the authors concluded with this information and this data that within the class of renin-angiotensin inhibitors, or RAS inhibitors, these findings support prescribing ARBs over angiotensin-converting enzyme inhibitors in the treatment of hypertension, predominantly because they're equally effective, but ARBs having a greater safety profile, including angioedema. So what's the implications for hearts? These recommendations, this data strongly support what we're doing. It strongly supports the recommendation of ARBs in the treatment protocol examples, including in our hypertension clinical pathway. It also supports the examples in the World Health Organization, examples of protocols and algorithms. However, it still strongly supports angiotensin-converting enzyme inhibitors where there is availability and cost considerations, since they both achieve the exact same beneficial outcomes. As opposed to the individual agent now, or the time of day of dosing of these medications, this study, the single pill combinations compared to multi-pill combinations regarding outcomes, or the START trial, looked at this issue. And again, the issue is adherence is a major barrier to hypertension control. That is clear. And the question is, does using single pill combinations, also sometimes referred as fixed dose combinations, compared to individual pills or multi-pill combinations, improve cardiovascular outcomes? And that's the point of this study. We've already had evidence that demonstrates that using single pill or fixed dose combinations does increase adherence, persistence, and blood pressure control. And this is in the WHO guidelines. However, the question has always been about outcomes. Well, this study looked at approximately 60,000 people, adults greater than aged 18. They were either on a single pill combination of at least 2 antihypertensive medications, or the same 2 antihypertensive medications in 2 separate pills. There were 4 different combination comparisons available to the investigators. They were identical medications, whether you were in the single pill or the multi-pill group for those medications. And they were followed up for at least 1 year. The outcomes were all-cause death and hospitalizations. Well, this is dramatic results. The previous studies we showed were equivalent, but very, very important data that influences our clinical decision-making. This is different. This study dramatically showed that all-cause mortality, as per 100 patient years shown on the left-hand portion of this study, was clearly decreased in the single pill combination group versus the multi-pill combination group, regardless of what combination you were on. as you can see. In fact, really interesting, there was one group was 3 medications in the single pill combination versus the multi-pill combination, and the difference was even more dramatic. I'll bet this was a smaller group. And you can see on the right-hand side that clearly, regardless of the combination that was looked at, the single pill combination strongly favored, obviously, the single pill, the outcomes, versus the multi-pill. So what are we to make of this? Well, clearly now, in addition to adherence, persistence, and blood pressure control, this study demonstrates that single pill combinations have lower incidence of cardiovascular events and mortality. And the authors state, and in clinical practice, they should generally now be preferred. Well, what's our implications? Again, it strongly supports what we've been saying and what we say now, that we prefer in the preferable treatment category using single pill combinations, but more importantly, starting with 2 medications together from complementary classes. And this is clearly in the hypertension clinical pathway. Let's now switch gears from pharmacologic treatment to clinical care. This is a more complicated study, but just recently published in 2023 in Lancet. Is studied the effectiveness of a non-physician community healthcare provider-led intensive blood pressure intervention compared to usual care. Again, the issue is team-based care. What is the effectiveness of a non-physician community healthcare provider-led program, but again, that was physician supervised, including intensive blood pressure intervention on cardiovascular outcomes, and at present time, this has not been firmly established. This was a study in 326 Chinese villages that looked at 2 groups. One, the intensive care, the non-physician community health provider-led initiative versus usual care in these 326 Chinese villages. Blood pressure levels were defined, et cetera. And importantly, the intensive intervention group used a simple stepwise treatment protocol in the intensive group versus the control group, if you will. That may become very important. The outcomes were cardiovascular events, as you might imagine, such as myocardial infarction, stroke, heart failure with hospitalization, or cardiovascular disease-related deaths during the 36-month follow-up of all these individuals. Well, this needs no description. Shown on both of these graphs, systolic blood pressure on the left and diastolic blood pressure on the right, the usual care group is shown in red. The intervention intensive non-physician-led group is shown in blue. And you can see a dramatic reduction in both systolic blood pressure of about 20 millimeters of mercury and diastolic blood pressure in the intervention group versus the usual care group. Wow. Well, what about outcomes? These 3 graphs show cumulative incidence of cardiovascular disease in the A graph, stroke in B, and all-cause death in C. Again, the 2 groups are represented by usual care in red and the intervention intensive treatment group shown in blue. And all 3, whether it's cardiovascular disease in general, stroke, or all-cause death, the intervention group had highly significant reductions in all 3. Well, that led the investigators to conclude that non-physician community healthcare provider-led care in terms of with an intensive blood pressure intervention is effective in reducing cardiovascular disease and death when compared to usual care. Now, remember, this intensive community-led group also had direct physician supervision. So what is the implications for hearts? It strongly supports recommendations for team-based care and pharmacologic antihypertension treatment protocols under physician supervision. Going back to the World Health Organization guidelines, the last recommendation in the guideline is to suggest support for team-based care under physician supervision. And this dramatic data further supports that recommendation of the WHO guidelines. And the last study we want to look at is disparities in hypertension care. This study is the blood pressure control among Black versus white adults following a quality improvement program recently published in JAMA. Again, the issue is, it's well known that a greater percentage of Black compared to white individuals have a higher prevalence of hypertension, have reduced clinical outcomes in hypertension treatment, or have worse clinical outcomes of their hypertension, and as well have a greater percentage of uncontrolled individuals compared to whites. So this study examined the change in blood pressure control in whites versus Blacks before and after a quality improvement program. The study was performed by our colleagues at Kaiser Permanente in Southern California. The individuals had to be 18 years or older and, of course, have documented hypertension. It was conducted from 2008 to 2019, but the QI program began in 2010. And remarkably, it consisted of a preferred medication algorithm as one of its components. The outcomes, of course, was blood pressure control as defined by a blood pressure of less than 140 over 90 millimeters of mercury. Well, the results were equally dramatic as some of the other studies we presented today. Number one, the Black-white blood pressure control rate significantly narrowed to about 2 to 3% difference between the two, with Blacks still having lower blood pressure control rates than whites. However, when compared to our national data of 15%, this gap of 2 to 3% was remarkable. Also, the percentage of individuals with blood pressure control, again, as defined by a blood pressure of less than 140 over 90, was almost 80% in the Black patients in the quality improvement program of Kaiser Permanente versus our national data of 37%, if you will, a dramatic difference in hypertension control rates. There was no difference in clinic visitation, treatment intensification, or follow-up after elevated blood pressures. So what does this suggest? It suggests that adherence was lower in all medication classes and that this should be addressed specifically in the future. So the quality improvement program, which consisted at least one component of an intensive treatment algorithm, markedly decreased, but did not eliminate disparities in blood pressure control between Blacks versus whites. So the implications for us is it again reinforces the core foundation of the use of a standardized pharmacologic treatment program in the HEARTS program. And it suggests, however, more focused interventions, perhaps focusing on adherence, are needed in Blacks with hypertension versus other demographic groups, in this case, whites. Well, what can we conclude from reviewing these studies over the last 2 to 3 years? Well, number one, several key studies have been published that are supportive or urge a consideration for change in terms of implications for HEARTS in the Americas. HEARTS is a living document with continued review and timely updates and changes given new evidence. These studies fit the guiding principles of the HEARTS program. These landmark studies also support the population-based primary care approach of HEARTS. Let's celebrate World Hypertension Day today and the key role that HEARTS continues to play in the detection and treatment of hypertension. I thank you very, very much from the University of South Carolina and University of South Carolina School of Medicine for being with us today for this celebration.
Bueno, excelente, profesor Don De Petty.
Excellent, Professor DePetty. He was our keynote speaker for today, and it is a way to end on a really high note. As I said in the beginning, this type of interventions can be suspect. And some of you have had reservations, some of the countries have had reservations, but let us not be distracted because we are on the right path. We are constantly reviewing the evidence to make sure that we are doing things well, but we need to go for it. We need to implement it. We need to continue to make progress, as has been demonstrated here by our champion countries, Chile, El Salvador, St. Lucia, and other countries that have great performance. They're doing well. We also presented new resources for the community of hearts countries, including the virtual course for managing medications and also the hearts app. We also talked about the regional approach of the clinical pathway, and we ended with studies that have practical implications for the hearts initiative. Now I'll yield it over to my colleague, Tara Malcolm. She's taking the temperature there of the group of people from the Caribbean who are all gathered together in St. Lucia. Over to you, Tara.
Thank you, Pedro. And how are you feeling? What do you say are some of the main takeaway heading back home to your respective country? And I'll start with you.
Good afternoon, everyone. The main takeaway is to strengthen the monitoring and evaluation of our CNCD efforts in the Bahamas. Thank you.
So monitoring and evaluation. What about Montserrat?
Okay, for Montserrat, we're in pre-implementation stage. So going back, I plan to involve the stakeholders, both private and public, to get on board with this program so that we can have standardized care for our patients and improve our control.
An important point, engaging the private sector in the implementation of hearts from the inception will help to strengthen and make it a success nationally. So Grenada, what do you want to add to this discussion?
Thank you so much for having us, and thank you to the countries that have already implemented hearts. Your advice and your experiences are a wealth for us because we see that a country of 110,000 people with 133 square miles, this is going to be easy for us. Whatever challenges come, we'll take it one bite at a time, and we're very excited. Thank you, Pajo. Thank you for everyone here. Thank you, Trinidad, St. Lucia, everybody, Bolivia, whoever's online. We're very excited to start implementing hearts in Grenada and seeing the impact of it.
Excellent. This is a community and we're all working together. Let's hear it for BVI.
Well, definitely going back, feeling re-energized. We have our clinical pathway. So just to reinforce use of the clinical pathway and now also to take advantage of the other pathway tools, the virtual courses, and also using a risk calculator. So I'm going back motivated, going back to motivate the team, and just making use of this great resource.
So the motivation is high, the resources are available. Let's get the last word from St. Vincent and the Grenadines.
Thanks, Tara. We have the evidence, we have the experience. We could do this and we should do this and we would do this. Thank you.
Short and sweet, just the way we like it. Pedro, over to you.
Bueno, ¿qué más decir?
Well, there's nothing left to say. Fabulous. This has been a wonderful opportunity to celebrate World Hypertension Day, advancing, hearing about science in action. Let me tell you that last year in the same webinar, we had 20 countries only, 12 countries fewer And now we have 32 countries, so 12 more who are completely committed to implementing hearts. We can save many lives, we can save a lot of money, and we can make people happier if we do what we have to do. We need to go back to our countries with the energy and the desire to do things better. So on a day like this, World Hypertension Day, um, congratulations and thank you to the panelists. We paid attention to what you said. The material is available on the Hearts webpage. It is on YouTube. You can download it. We have certificates for all participants who have been online. We have certificates. You will receive them. And if you were all the time connected on the webinar, you'll receive your certificates. And those who are at St. Lucia right now, have a wonderful trip back and safe trip back to your countries. Working with St. Lucia has been wonderful. We've had great hosts there, and we want to thank the APAHO office in the Caribbean, and we have had a wonderful team. We also want to thank our interpreters, our usual, and Jenny Rodriguez, as well as the technical team from PAHO. This has been a wonderful adventure. We didn't know how this hybrid presentation was going to work, and I hope you have been patient with us and the small glitches that there have been. But we are ending here with music, and now we have the end with music. Over to you, production, for playing some music.